The 5 question, topography of the liver. Liver is located inside of the right hypochondriac region, epigastric region, and some part of the left lobe on the left hypochondriac region. Liver is a mesoperitoneal organ. It has two lobes, right lobes and left lobes. There are two structures: anatomical structure of the liver and surgical structure of the liver. Anatomical structure of the liver includes the 4 lobes: the right, left, caudatus, and quadratus. Surgical structure of the liver divided on the right lobes and the left lobe. Every lobe divided on the segment. The liver has 8 segments. The left lobe has 3 segments. The right lobe has 5 segments. The unit of the liver is lobulus. Lobulus is a hepatocyte, which located around of the central vein, and peripherally you can find the triads. The artery, the lobulus artery, lobulus vein, and lobulus bile duct. The liver has some ligament, coronarium ligaments, falciform ligament, teres ligament, hepatoduodenal ligaments. Hepatoduodenal ligaments contain the portal vein, hepatic artery, and bile duct. It means during the liver bleeding, you can clamp the hepatoduodenal ligament and stop bleeding. You can do it only for the 50-20 minutes, not more. After that, you should stitch the wound of the liver or tamponade the liver by the omentus major, the part of the omentus major. Also, you should know the surgical access to the liver. The surgical access to the organs of abdominal cavity is called the laparotomy. And there are 5 kinds of laparotomy: longitudinal, horizontal, obliques, angle, and combined. For surgical access to the liver, you can use or oblique laparotomy or angle laparotomy. The popular surgical access to the liver is a Kocher surgical access. It's an incision below of the right costal arch 2 centimeters and along of the costal arch. Or you can use the Rio Branco. Rio Branco surgical access is an angle access start from the xiphoid process of the sternum, make longitudinal 5 or 6 centimeters along of the middle anterior line, and after that the direction of the incision should be parallel to the right costal arch. Do you have a question? No. Topography of the parotid mesenteric region. Firstly, also the borders. I forgot to the 5 questions I return. I forgot to say blood supply of the liver. Liver has 3 blood ways. Artery blood ways. It's a common hepatic artery which start from the celiac trunk. The common hepatic artery transforms to the proper hepatic artery, and proper hepatic artery inside of the hiatus hepatic divided on the right and left hepatic artery. Right hepatic artery supplies the right lobe, left. The second way is the portal way. The portal vein is formed behind of the head of the pancreas by the superior mesenteric vein and splenic vein, and drains blood from the organs of the abdominal cavity to the portal vein. And the last way is a veins way. The liver has a 3 or 4 hepatic vein. The hepatic vein drains blood to the vena cava. Topography of the parotid mesenteric region. Parotid mesenteric region, the borders superiorly is a zygomatic arch, inferiorly is inferior margin of the mandibular, anteriorly is anterior margin of the masseter muscle, and posteriorly the line, the vertical line which draw through the hiatus acousticus externus. The layers of the parotid mesenteric region: skin, subcutaneous tissue, superficial fascia, proper fascia. Proper fascia covers the parotid gland and forms the capsule of the parotid glands and covers the masseter muscle. After that, the bone and cellular spaces. The mesenteric region contains the parotid gland. Parotid gland is a great salivary gland which produces the salivary. It has a own duct, the own duct opening inside of the oral cavity, second superior molars. The parotid glands supplied by the vegetative branches of the glossopharyngeus nerve. Glossopharyngeus nerve is the 9 pares of the cranial nerve. The facial nerve pass through the parotid gland, and during the inflammation of the parotid gland, this nerve may be pressed. The facial nerve is a mixed nerve which has motor branches, sensory branches, and vegetative branches. Through the parotid glands, the motor branches is passed. The motor branches divided on the 5. It's a temporal, zygomatic, buccal, mandibular, and the cervical or neck branches. These branches supply the mimic muscle. During the pressing of the facial nerve, this muscle loses sensation, and the patient may have a paralysis of the face on the one side or another side. The pure inflammation from the parotitis may spread to the oral cavity, to the deep facial region, and through the fossa pterygopolitan goes to the inside of the superior and inferior floor of the abdominal or peritoneal cavity. The first part of the small intestine is the duodenum. Duodenum has a 4-part superior, um, descending part, horizontal part, and ascending part. The superior part covered by the peritoneum on the all sides. The descending transverse and ascending part covered by the one side, it means extraperitoneum. The bile duct, common bile duct, and pancreatic duct are opening to the descending part of the duodenum. Duodenum does not have a mesenterics, and the duodenojejunum flexure attached to the second lumbal vertebra by the duodenum suspensorium ligament, which called tracer ligament. It plays where the jejunum is start. The jejunum is the second part of the small intestine. It covered by the all side. It means intraperitoneum. A jejunum has a mesenteric. And the next part of the small intestine is ileum. Ileum also covered the wall side and has a mesenteric. Now, how can you recognize the ileum and jejunum? There are not differences between jejunum and the ileum, only uh, length. The length of the small intestine is 6 to 7 meters. 24 centimeters is a duodenum, and other part ileum and jejunum. If you divided them all small intestine on the 5 same part, the 2/5 is a jejunum, 3/5 is a ileum. Now, the differences between small and large intestine, you should know it. The firstly is the large intestine has three particularities. First is tenure, free tenure, gallstrea, and epiploic process. The small intestine does not have it. Sinuses. Mesenteric sinuses is a pouch which located inside of the inferior floor of the peritoneal cavity. The shape of the mesenteric sinus is like a triangle. There are two mesenteric sinuses, right mesenteric sinuses and left mesenteric sinuses. The borders of the right mesenteric sinuses laterally ascending colon, superiorly transverse colon, and the medially the roof of the mesenteric. Left mesenteric sinuses, medially roof of them, mesenterics laterally the descending colon, and inferiorly the sigmoid colon. Inside of the mesenteric sinuses, the pathological fluid may concentrate. Inspection of the organs of the abdominal cavity. During the trauma of the abdominal cavity penetration wound, you should make revision of the organs of the abdominal cavity. You should start from the right side of the abdomen. Firstly, you should see the liver, after that the spleen, after that the root of the mesenteric. Root of mesenterics attached superiorly at the left of the second lumbal process and inferiorly of the right sacroiliac joint. The next, you should revision the large and small intestine. Also start right. After that, uh, upper revision of the transverse colon, and after that, the left side of the abdominal cavity. Techniques of intestinal resection and using is costal anastomosis, end to end, side to side. Um, Techniques. Every surgical operation includes three stages. First stages is the surgical access. Surgical access to the organs of the abdominal cavity is called laparotomy. I said how many types of the laparotomy you should know. The second stage is the techniques or for example, the intestinal resection. Firstly, you should mobilizate the part of the intestine which you will remove. The small intestine is usually has a mesenterics. Mesenterics contain many vessels and nerves. Before the resection, you should make the opening by the hemostatic forceps inside of the mesenterics and clamp and ligate the vessels which supply the wall of the intestine which you will remove. After that, you should take the intestinum clamp. There are two types of the intestinum clamp, smooth and hard. Hard you clamp for the up part which you will remove, and the smooth to the part of the intestinum which you will stitch. And between the intestinal clamp, you should cut the intestinal. After that, you should make intestinal anastomosis. Intestinal anastomosis is divided on their four types: end to end to side, side to end, and side to side. The diameter of the small intestine is not big as compare of the large intestine, but better make anastomosis side by side. Firstly, you should make the stump of the proximal and distal end of the intestine. What does it mean? You should stitch the proximal end and distal end. This information you can see on the presentation on the portal of the education. And after that, connect them the proximal and distal end by the side. Make opening and stitch. Firstly, you should form in the posterior labrum of the anastomosis, and secondly, the anterior labrum of the anastomosis. Mhm. No, the next question, topography of the inguinal canal, I said you. The topography of the posterior region of the forearm and back of the rib. No, it's the same of the anterior region. You should call the borders of the posterior region superior, inferior, and lateral and medial layers start from the skin and finish into the bones. Mm. Uh, Also, it's the same of the wrist and uh, surgery of the panarism. Panarism is a pure inflammation of the smooth tissue of the finger. Uh, Inflammation of the nail, um, maybe also inflammation of the bone, also maybe. The inflammation is of the bone is called osteomyelitis. Inflammation of the tendon is called tendovaginitis. And inflammation of the smooth tissue is a panaritis. You should make an incision on the lateral and medial surface of the phalanges, not anteriorly on the palmar surface and not the dorsal surface. Find the picture with the surgical treatment of the panaritis, tendovaginitis, and osteomyelitis in your workbook, if you answered. Topography of the anterior said, topography of the carotid triangle. Carotid triangle is located off the neck. Carotid triangle has three borders. Posteriorly or laterally, the anterior margin of the sternocleidomastoidus muscle. Superiorly is the posterior belly of the digastric muscle, and anteriorly of the superior belly of the omohyoid muscle. Inside of the carotid triangle, you can find the carotid bandage. Carotid bandage includes the common carotid artery, the internal jugular vein, and vagus nerve. The vagus nerve located between and posteriorly of the carotid artery and carotid vein. Carotid artery divided on the external and internal carotid artery. The level of the division may be or the superior margin of the thyroid cartilage, 70%, maybe on the hyoid bone, 20%, and maybe on the angle of the mandible. The carotid bandage is formed by the parietal lamina of the internal cervical fascia. And if this bandage or this fascial vagina contain the pure, you should opening this vagina how the incision should be along of the sternocleidomastoidus muscle, anterior margin of the sternocleidomastoidus muscle. You should cut skin, subcutaneous tissue, superficial fascia, proper fascia, and the parietal lamina of the endocervical fascia, and evacuate the fluid. The next question, topography of the anterior region of the leg. Also the borders. The borders superiorly the crossed line which draw through the tuberosity of the tibia, inferiorly and 2 finger above of the lateral and medial epicondylus, and the lateral and medial borders is a vertical or longitudinal line draw through the lateral and medial epicondylus. Layers of the anterior region of the leg skin, subcutaneous tissue, superficial fascia, proper fascia. Proper fascia gives the sabs which attach to the fibula and tibia and divided the muscle on the three groups. The anterior groups, lateral groups, and posterior groups. The muscle of the anterior groups includes the tibial anterior muscle, the extensor hallucis longus, extensor digitorum, and the lateral group includes the short brevis and longer fibula muscle, and posterior group includes the triceps muscle, posterior tibial muscle, and flexor digitorum, and flexor hallucis longus. The anteriorly vessels nerve bandage is located. It's anterior tibial artery to anterior tibial nerve, and the perineal nerve, superficial and deep perineal nerve. Superficial perineal nerve supply the muscle of the lateral compartment, and the deep supply the muscle of the anterior compartment. Trunk. Where is it going? Classification of the limb amputation. Amputation is the removing of the part of the superior upper or lower limb. According the classification according of the section of the soft tissue. First type is a circle, second oval, a third flaps. There are maybe one flap, two flap, or three flap. Um, the plastic amputation of the leg. Plastic amputation, the indication is a gangrene, the diabetes, wounds of the um, um, foot, or the traumatic amputation of the foot. The first, it's a flap amputation. You should make firstly the two flaps anterior and posterior. The posterior flap should be longer because the muscle of the posterior compartment is the biggest and better closed the bone by the posterior group of the muscle. Uh, you should cut the skin, subcutaneous tissue, and the muscle. After that, you should close and ligate the vessels. The next, you should cut the uh, nerves. And the last, you should scrub the periosteum from the fibula and tibia, and after that, sew the bone. First, let them fibula. You can use the electric saw or a jiggly saw. And the second, you should sew the tibia. After that, you should close the fibula and tibia by the fascia, the proper fascia, and by the muscle. You should stitch the posterior and anterior and lateral group of the muscle or compartment, muscle compartment. And the last stage is stitch the skin and subcutaneous tissue. You can use or mattress uterine or interrupt uterine. No, topography of the diaphragm, I think I said you. Topography of the mental bursa or lesser sac. Lesser sac is located inside of the superior floor of the abdomen. It has some walls, anterior walls, amentus minus, includes the three ligaments, hepatoduodenal ligament, hepatogastric, and gastrophrenic ligament. The next, the posterior wall of the stomach and the gastrocolic ligament. The inferior wall of the lesser sac is a transverse colon and mesocolon. Posteriorly is a peritoneum which covered the duodenum and pancreas. And superiorly is the left lobe of the liver and the diaphragm. Lesser sac has a one opening, which called the piploic opening, and through this opening, the lesser sac connect with the abdominal cavity. Topography of the pancreas. Pancreas is the organs of the superior floor of the abdomen. The holotopy, the left hypochondric region. Synthopy located behind of the stomach, upper of the kidney, left kidney, behind of the skin, in front of the abdominal part of the aorta and inferior cava vein. The pancreas has head, body, and tail. The pancreas has a pancreatic duct opening inside of the descending part of the duodenum. The pancreas produces the pancreatic juice and the hormones. Pancreas covered by the peritoneum only one side, and its position and relationship is called extraperitoneum. It means the surgical access to the pancreas is very difficult. The blood supply of pancreas supply by the superior anterior and posterior and inferior anterior and posterior pancreatic duodenal artery. The vein blood range to the same name of the veins and range to the portal vein. Operating access to the pancreas is called laparotomy. You can use a superior medial laparotomy or a transrectal laparotomy or an oblique laparotomy. You should cut the mesenterics of the transverse colon. The mesenterics of the transverse colon is called a mesocolon, and after that find the pancreas. Mhm.
Increase.
The third
So you can
question:
see that
topography of intercostal
extracellular space
space
will be
and
decreased,
subperiosteal rib
and
resection.
also intracellular
Intercostal
space will be
space is a
decreased
space
also.
which located
If you have
between superiorly
hypertitration,
inferior
ISS motor,
margin
so
of
you
the
must
rib,
know that
inferiorly
patient
superior
has
margin
a
of
lot of
the
water
rib,
in the body.
anteriorly
So you can
thoracic
see that the
fascia,
water will be in extracellular
internal
space. Water
thoracic
will be
fascia.
normal volume.
Between the
If you will
thoracic
have
and the
hyposmotor
thoracic fascia, there
hypertitration,
are
so you
three
can see
muscles:
that the
external
patient
intercostal
will be keep
muscle,
water in the
internal
body, so
intercostal
water
muscle,
will
and
be
inner muscle.
increase in the body.
Between the
So
internal and
you can
inner
see that
muscle,
the volume of
the
extracellular space will
intercostal
be
bandage is
increased, and
located.
also
Intercostal
volume
bandage
of the cells
includes
will be
superiorly
increased also.
intercostal vein, medial intercostal
You will
artery,
have
and
hyperosmolar
inferiorly
hypertitration,
intercostal nerve.
so you can see that
Intercostal artery
sodium
is
concentration in the plasma
branches
will be
anteriorly of
increased.
the internal
Sodium from the
thoracic
plasma
artery.
go to the extracellular
Posteriorly
space,
is the branches of
and
the
from
thoracic part of the
extracellular
aorta.
space and from
Intercostal nerve
vessel
is
where will be a lot of water because water not go outside from the
spinal
body.
nerve.
So water from
Start from the
vessels will
spinal
be
nerve.
go to the
Uh,
extracellular space.
the practical means
Sodium will
of
be
the
a lot of in
intercostal space.
extracellular space. So
Inside
from
of
the
the
cells,
8
all the
and
water will
7
be go to
intercostal
the
space
sodium.
or a
So
second or
you
a
can
two,
see that the
you
volume
can
of
make
cell
the
will be
puncture
decreased,
of the pleural
and
cavity.
all of water will be
Puncture
kept
of
in
the
extracellular
puncture of
space.
the pleural cavity you must
We must
make
to know that
along of
typical
the
form of
superior
water
margin
imbalance
of
is
the
edema.
rib
So you can see
to
here
prevention
classification of
the
edema
damaging
by
of the
its
intercostal
localization.
nerve
So you must to
artery
know that
and
we have
vein,
anasarca,
which
so
located inside
widespread
of the
swelling of the
costal
skin.
notch, the
Your patient
lower
can
margin of
has
the rib.
edema of the lungs. Also, you must
Superostal
to know
rib
this
resection
problem with
is
lungs. So your patient can has problem
manipulation
with brain.
which
So
used
this
during
type of
the
edema
surgical
called
access
edema
to
of
the
the brain.
organs of the thoracic cavity.
Also,
I think you
pathological
know the
accumulation of
two
fluid in a body
surgical access to
cavity
the
called
organs of the thoracic
hydrocele. So
cavity:
is called
thoracotomy
ascites,
and sternotomy.
hydrothorax, hydroperiocardium, and
Subperiosteal rib
hydrocephalus.
resection used during the
Oh, in this
Thoracotomy.
photo, you can see
Thoracotomy
that
divided on
after
the
cutting
anterior lateral, and
body
posterior
hand,
lateral.
so you can
The
see pitting
subperiosteal
edema
rib
of the
resection
skin.
used during the
So
lateral
if this will be OCT,
thoracotomy.
so you never see this
There are
pitting
surgical
edema
instruments, the
of the
special
skin.
surgical
But
instruments
if you can
for
see
the
like this
subperiosteal rib
pitting
resection
edema, so you
includes
must
the
say, and you
Turas
must
patra,
write in your case
Farabe's
that
and
your patient
Duayendra's
have
patra.
edema.
The
So
next
your
is a
patient has
scalpel,
problem with
the
imbalance in
rib
organs in
scissors,
the
the
body.
special rib scissor.
So also we have some classification of edema by etiology. So you can see here what's the problem, what's the
Incision. You
case
should
in each
make
organ
incision
you
along
have
of
the
the
problem
superior
with your
margin
patient. So if your patient
of
have problem
the
with the heart,
rib.
so you called
The level
this
of the
type
rib
of
depends of
edema
aim of the
cardiogenic.
surgical operation.
If the problem
If
is
you
kidney,
want
so you call
to
this is renal
find the,
edema. If the
for
problem with
example, the
liver, so cell
apical
hepatic
lobes of the
edema.
lung,
Also
you should
cahectic
make resections
starvation. So if
along
your
of the
patient
third
will be
or a
decided
second
not
superior
eat
margin of
food,
the
so
rib,
you can see
and
edema
others.
after not eating.
After that,
So also you
you
can see
should cut
inflammatory.
skin,
So this is
subcutaneous
processes
tissue,
we spoke before.
superficial
So you can
fascia,
see
proper fascia,
that your patient have
and
uh,
the muscle.
phlogogen factors. And
Muscle
if you can
better
see
separate
inflammatory, so it will be
by
say
the
inflammatory edema. So
hemostatic lung,
also
not
you
the
can see
scalpel,
here we have
because if
toxic
you cut
edema,
the muscle
allergic
fibers,
edema,
the
neurogenic
patient may
edema,
have a
and
bleeding.
lymphogenic edema.
The next, you should take the Farabe-Frask patra, a scrap periosteum which covered the um, rib. Um, Anteriorly, scrub the
Also, we have
Farabe-Frask patra
classification
used
of
only the
edema by
scrubbing
a
of
leading
the
factors in its
periosteum
agenesis.
which covered the
So you must
anterior surface
know,
of the
you
rib.
should to know
For the posterior
5
surface,
factors.
you
So
used
hydrodynamic,
the
osmotic,
Duayendra's
anocotic,
patra.
membranogenic,
After the
and
scrubbing of the
lymphogenic.
periosteum, you
So
should take
you
the
must know
rib
if
patra
edema will
and
be happened,
cut the
one
rib.
of these factors will
The
be
next,
stuck,
stitch
and another
posteriorly the
4
periosteum,
factors
anteriorly the
will be
periosteum, and
involved
stitch
in
the
edema.
leads of the anterior or posterior thoracic wall. Do you have a question for the first?
Also, maybe you remember,
Tell
we
me,
have
please.
Starling equation. So we have a filtration pressure is
The second
calculated
question, topography of
using
the inguinal
hydrodynamic
canal.
pressure of blood
Inguinal canal
plus
is the weak
oncotic
places
pressure
of
of
the
blood
anterior abdominal wall.
minus
Inguinal
hydrodynamic
canal
pressure
is
of tissue
located
fluid
inside of
and
the inguinal
plus
region.
oncotic pressure
There
of
are two
tissue fluid.
regions, right and
So
left
you
inguinal region. It means there are
see
two
here
inguinal canals,
some
right
amount,
and
but
left.
we not ask you about
Inguinal
this amount,
canal
but you
has
must see
four walls
that
and two
pressure
rings.
in arterial
Anterior
capillaries
wall is
will be higher
aponeurosis
than
of the
in venous
external
capillaries.
obliquous muscle.
So,
Posterior wall
and this happened
is a
due
transverse
for
fascia. Superior
processes
is
of filtration. So if you have
a lower
this
margin of the internal obliquous
pressure
muscle and
in arterial
transverse muscle.
capillaries, so water
Inferiorly
and
is the
ions and
inguinal
nutrients
ligament. There
go
are
from
two rings,
capillaries to the
superficial ring and deep ring. A deep ring is a
extracellular space. So you
orifice
can see
inside
this
of the transverse fascia.
nutrients, you can see
Superficial ring
water in extracellular
located
space.
between the
So you must
pubic
know that
syphilis and pubic tuberculum,
scattering forces
where
can
the
change if we
lateral and
have
medial
promote
leg of the
development
external
of
aponeurosis of external obliquous
edema.
muscle attached. The inguinal canal contains some
So
structure.
can change
The female contains the teres ligaments
hydrodynamic
and
pressure of blood. So this is amount can change. So will
inguinal
be called hydrodynamic edema.
nerve,
If will be
and the
change this
male,
volume
the
of oncotic
spermatic
pressure
cord, which
of
include
blood, so you
ductus
can see
deferens,
oncotic
then
edema. And
veins,
if
plexus,
this value will be
some
changed
arteries,
in
testis,
tissue
arteries, and
fluid,
hemostatic
so
arteries,
we will be
and lymphatic
speak
vessels and
about
nodes,
oncotic edema.
and also ileoinguinal
So
nerve.
here you can see the patient with lymphogenic edema
Herniatommy
of the
for
left
strangulation
extremity.
hernia.
So you can see one leg normal
Hernia
size
is
and
an
legs,
protrusion of
left
the
leg more
organs from the
bigger
abdominal cavity
because the
through
water will
the
be
weak
deep
places of
in
the
the
anterior abdominal wall under the
body,
upper
in the
necrosis.
lymphatic vessels,
And
and
the hernia, I think you
lymphatic
know,
vessels work
has
not good, and you can
hernia
see
gates or
the
hernia
leg
orifice,
will be
hernia
more
sac,
bigger
and hernia
than right
contents.
leg.
Hernia
In your
gates
cases,
or
you will
hernia
have
orifice
some
is a weak
questions about
places of the anterior
pathogenesis of
abdominal
edema.
wall.
So I
It
show
may be
to you
the
some pathogenesis
umbilical
of
ring. It
different
may
type
be
of edema,
inguinal canal
and you must
or
write
external
in your answer in for
inguinal ring.
cases. So
It may be
pathogenesis of the renal edema can
femoral
be
ring.
nephritic edema or
It may
nephrotic
be
edema. This is
albuline
different because the
and
different type
spigelic
of
line.
causes start
Inside of the
development
hernia
of this
orifice,
type
the
of
hernia
edema.
site may be
So you can see
pressed by the muscle, and this
nephritic edema,
hernia
so
is called
inflammatory injury of the
strangulation.
renal glomeruli.
Uh,
After that
the
will be decreased blood
muscle
flow in the
which
glomerular
press the
capillaris.
neck of the
After that
hernia
will be
sac
activation of the
may
renin-angiotensin
press the
aldosterone system,
organs. It may
and
be a
after
loop
that
of
you will be
the
have that increase
intestine.
distal reabsorption of
During the
sodium and
pressing,
water in renal
the
tubes. And
intestine
it will be
loop
led to the retention of
lose
sodium
the
and
blood
water in
supply,
the body.
and it goes to
If
the
you can see
necrosis of the
nephrotic
tissue
edema,
of
the problem will
intestine
be
loop.
increased porosity of the
It means
glomerular filtrum.
during the
So you will be see
herniatomy
massive
for
losses of
strangulation
protein
hernia.
in urine.
Firstly,
This will be
you
led
should
to
cut
decrease oncotic
the
pressure in the
uh,
venous capillaries. So after that
hernia
will be
orifice.
retention of sodium and
The
water in the tissues,
plastic
so
repair of the
circulating
inguinal
blood volume
canal
will be
bassine
decreased.
methods
After
uh,
that,
uh,
if circulating blood volume will be
includes the
decreased,
stitching,
in the
the
kidney will be activation production of renin.
transverse
After that will be activation of the renin
fascia,
angiotensin aldosterone system. After
uh,
that, you can
no,
see
the
again increased
internal
distal reabsorption of sodium
internal
and water
obliquous
in
muscle,
renal tubules,
transverse muscles,
and
transverse fascia
also will
to the
be too late
inguinal
to retention of
ligament
sodium and
behind
water in the body. Not
the spermatic
different
cord
nephritic
or
or
teres
nephrotic
ligament.
edema, but the end will be the
Do
same.
you
So
have
you
a
can see
question on
here
the second?
the different case, the different way, but
Hmm?
the end will be one.
Tell me, please.
No, ma'am.
Mm,
No, ma'am.
mm.
So
And the
pathogenesis
next,
of the
topography of the mammary
cytotoxic
gland.
edema of
It's
the brain.
also
So you
very
can see here
simple.
in the
You
slide,
should call the borders of
you
the mammary
must
gland
to
superiorly
start to
fluid
write
rib,
your answer from
inferiorly
injury
sixth
of the
rib,
brain cells and
medially
explain.
the lateral
After
margin
that,
of
we
the
write
sternum,
increase in the
laterally
volume
the
of the
anterior
intracellular
axillary line.
compartment of the brain.
The
After that,
mammary
you can see
gland
elevation
includes
of the
50-20
intracranial
lobes,
pressure.
which have
After that will be
every lobe
compression
has
of the
a
large
own
venous and pure
duct
vessels of the
opening
brain.
to the
After that,
nipple of
will
the
be see
mammary gland.
decrease of the brain
Blood
perfusion.
supply of the mammary gland, intercostal
After that,
artery,
will be
the
decrease of the
lateral
brain perfusion,
thoracic
and it will
artery,
be
and
increase
internal thoracic
intracapillary
artery.
hydrostatic
The
pressure.
vein drainage,
After that, you will be
also
decrease
the lateral
reabsorption of water in brain
thoracic vein
capillaries,
drainage to the
and will be
axillary vein,
increase
the
mobility of brain
thoracic
capillaries.
internal and
After
intercostal
that,
vein,
increase volume of
which drains to
extracellular
the
compartment of the brain,
superior vena cava.
and after that you will be
Lymphatic
see
drainage.
edema
The
of the brain.
lymph drains to the axillary
Also,
lymphatic
if
nodes. There
will be
are 5
decrease of
groups
brain
of
perfusion, so
lymphatic
you will be
nodes:
see brain
the
ischemia.
central,
If
middle,
you will
lateral,
have
superior, or
brain ischemia,
absent,
so it will
inferior.
be led to the injury
And
of the
also
brain cells
the
and their swelling.
lymphatic way
So this will be like
located
cycle,
or may goes
this
to the
form of
inguinal
injury of the cells.
lymphatic nodes, the abdominal
So
lymphatic node,
after
and to the
increasing,
sternal lymphatic node, subclavian
after
lymphatic node, and neck lymphatic nodes.
impermeability of the blood-brain barrier,
Resection
that
of
is
the
the
mammary
main
gland.
reason, the main
There
case for
are some kind
vasogenic
of
edema of the
resection
brain.
of the mammary gland.
After
It's a
that, you will
total
be
resection
diffusion
or
progress
sectoral
in the
resection of the
intracellular
mammary
space
gland.
will be increased
Indication to
oncolytic pressure. That
resection
will
of
be
the
increased
mammary
volume
gland.
of
It may
extracellular
be
compartment of the
inflammation,
brain. Will be
abscesses,
increased
and
intracranial
usually
pressure.
the tumor.
After that, you will see here that
If
compression of
the
the venous and vein
tumor
vessels in the brain
is not
will
very
be led
big,
to decrease in
you
the
should
brain
use the
perfusion.
septal
In one
resection.
way,
I
you can
said
see
the mammary
increased
gland can be
intracapillary
divided on the 4
hydrostatic
sectors:
pressure. Another way,
superior
you can see
lateral and
brain
middle
ischemia
septal
led
and
to swelling of
inferior
the brain,
lateral
and
and
again you
middle
can see cycle
section. You
that
should remove the
led to the
or superior or
increase
inferior
intracranial pressure.
lateral or medial septal. It
You can see
depends on
this
the
way, you
localization
can
of
see
the tumor.
increase intracapillary
If
hydrostatic
a woman
pressure will be led
has a
to
metastasis
decreased
of the
resorption of
cancer of
sodium
the
in the brain
mammary gland,
capillaries,
you should
will be led
make
to
radical
increase volume of
mastectomy.
extracellular compartment of
Radical
the brain.
mastectomy
It
includes
also
removing
increase
of the
intracapillary
total
hydrostatic
resection
pressure,
of the
will
mammary
be led
gland,
to
removal
increase
of the
permeability of the brain
mammary
capillaries.
space and the um, pectoral major muscle, and
And
also
at the
removing
end, you
of
must
the
write
axillary
will
node,
be
the central
vasogenic
and middle
edema of the
axillary
brain.
node, which located inside of the
Edema of the
axillary
lungs can be
cavity.
cardiogenic
Do you
and
have a question?
non-cardiogenic, so it can be toxic, hyperoxic, especially
The
in
fourth question:
IABS and
topography of the anterior
narcotic
region of
drugs
the forearm.
overdose, and at high
Firstly, you should set the
altitudes has
borders.
great
The
physical
borders
strain.
of the anterior region of
So
the
if
forearm.
you'll find
Superior
in your
borders
patient
are 2 finger
problem with
below of
lungs,
the line which
or
connect the
you
lateral and
must
middle
write
epicondyles of
pathogenesis
the humor.
of the lungs edema. So
Inferior,
if
the
you
two
will see
finger
that your
above
patient have
of
problems
the
with
line
heart,
which
so it will be
connect the
cardiogenic
styloid
edema.
process of the ulnar
Start
and
from the problem with heart
radial.
will be decrease of the cardiac
Laterally is
output. That
lateral
will be
and middle is the
increasing pressure in
longitudinal
the
line
left
which
atrium,
connect
will
the
be led
lateral
to
and
increase
middle
of the hydrodynamic
epicondyles of
pressure
the
in the
humor
lung
to
capillaries,
the
will be led to decrease
styloid
resorption
process
of
of the
water in the
ulnar
venous
and
portion of the
radial.
lung capillaries,
Um,
and it will
the
lead
next
to
Velez,
edema.
you should say Velez.
If you can see
First layer
toxic
is the
edema in the
skin,
lungs,
second
so you can see injury of the
subcutaneous
capillary
tissue,
endothelium,
the
and
next superficial fascia, and
type
the next
1
proper fascia.
pneumocystis and
Proper
destruction
fascia
of
give
the
passage which
surfactant.
attach to the
That you will write exit of walking
ulnar
proteins
and
in
radial
the
bones.
intracellular space of the
And the
lungs,
next, the
will be led
muscle
to
layers.
formation of
The
the
muscle
fluid in the
layers of the
lumen of
anterior
the
region of the
alveolus,
forearm can be
and
divided
after
on the
that
3
you will be
groups:
write edema.
superficial, middle, and deep.
If your patient will
Superficial
bleed
includes
a lot of sodium, for
the
example, or will be have the problem with
flexor carpi ulnaris and
hormones,
radialis,
and you can see
the
another
longus palm muscle,
causes, for example, dehydration
and
or
the
profuse osmotic diarrhea
flexor
or profuse
digitorum
osmotic ureasis
superficial.
or neurogenic or
The
necrotic
middle layers
diabetes
includes
insipidus.
the
So you
flexor
can see that
digitorum
sodium
profundus
concentration in the blood will be more
and
than 145 millimoles per liter of
pronator
plasma,
teres and
and this condition will be called
the flexor pollicis
hypernatremia.
longus
So how we
and
can
pollicis
see in your
brevis.
patient? So you must
And
find
the
some
deep
manifestation in your
muscle
patient.
includes
So you can see
the
that your patient will be
pronator
say
status.
that he feel weakness, he feel disability,
Contains
he has to
some
focal
vagal nerve bandage.
neurological
There
symptoms,
are ulnar
he
artery,
has
the great artery,
symptoms,
ulnar artery,
and
and
at
radial
the end he
artery.
has
Operative access to the
coma.
ulnar neurovascular bandage you should make along of the imaging line. Imaging line of the ulnar artery is a line which connects the medial process of the ulnar bone. Um, Ulnar neurovascular bandage includes the ulnar artery, ulnar nerve, and two ulnar veins. The ulnar nerve supply the flexor carpia ulnaris and the ulnar part of the flexor digitorum profundus. If this nerve will be damaged, the patient lose sensation on the palm surface of the fifth finger, fourth finger, and half of the third finger. On the dorsal surface, fifth finger and half of the fourth finger. And the patient will have a tiger hand. Do you have a question?
No, ma'am.
The five question, topography of the liver. Liver is located inside of the right